Good afternoon, everybody. My name is Maria Restrepo Toro, and I am the co-director of the New England Mental Health TTC. The New England Mental Health TTC Transfer Center is partnered with, is hosted by the Yale Program on Recovery and Community Health, and is conducted in partnership with C4 Innovations, the Harvard Department of Psychiatry, and the Center for Educational Improvement. And it is fantastic to have you today at this event. Next. Today, we are here to talk about our reach. Our reach is our passion and the New England Mental Health TTC to really discuss issues related to racial equity and advancing cultural humility within your organizations. And we are doing today the diversity talk, which really is a continuation of the conversation we started last month with Dr. Isom. So we are delighted that you're here today. Next. It's very important that everybody has their microphones muted. We'll discuss maybe later on, there's going to be a chance for us to unmute since we're here to have a conversation. Closed caption is available for this event. You really need to click on the closed caption and CC icon at the bottom of your Zoom screen so you can have that option available to you. We are recording this session and will be available in 24 hours of this presentation. The same happened with the presentation we've had before. There are information about certificates of completion can be sent as a follow-up email in our network email. And if you have any questions around this webinar, please use or raise the hand or just discuss it on the chat. I will be continually monitor the chat and any of our team can answer the questions. Next. As a disclaimer, all the REACH webinars are prepared by the New England Mental Health Technology Transfer Center, which, as I said, is an agreement. It's funded by the Substance Abuse and Mental Health Services Administration. So everything that is cited, all the sources are really under the New England Mental Health TTC domain. And the opinions expressed here are solely our views and doesn't reflect any official position from the Department of Health and Human Services. Next. One of the amazing things that this network has is that we are committed to use affirming, respectful, and recovery-oriented language in all the activities that we do. We always hope that through our work, we inspire people. We use a strength-based, hopeful language. We want to avoid person first and free of labels. We don't want to talk with making assumptions or judgments about people, and we want to be very respectful and clear. So therefore, we invite all of you to really, also follow those guidelines. That includes in the chat as well. Next. And as I said, the REACH initiative is really a vision that of the New England Mental Health TTC that started over a year and a half ago. And what we really position ourselves to be a cultural responsive organization that is really committed to advancing health equity. And we started to do this journey. And now what we're doing here today is invite you to join us in this journey. And the goal of this learning community is to really help you organization. And we want to provide you guidance, enhance on learning opportunities, and then bring some experts like the one we have today to really support your journey towards more practices in your behavioral health treatments, recovery, or whatever services you do in this field. And lastly, this diversity talk is really an opportunity as an opportunity to really extend our conversation. Why? Because last month we brought a fantastic speaker that you're going to have an opportunity to have today a conversation with, and we started to talk about how then we talk about diagnosing disparities, all these other issues, and we want to have this opportunity to extend this, and for you to know that if you do want to continue the conversation, the New England Mental Health TTC is clearly to support your journey as a more individualized technical assistant. So I want to acknowledge my entire team. We are joined by a fabulous team, Ingrid Patchett, Vanessa Roski, and also Janan Wyatt, who is going to be our facilitator for the conversation today. So thank you, Jana. Take it away.
Thank you and welcome everyone. I'm excited to be here this afternoon. I'm just going to take a moment to introduce our speaker for this afternoon, Dr. Jessica Isom. Dr. Jessica Isom is a board certified community psychiatrist and clinical instructor in the Yale Department of Psychiatry. She primarily works in Boston as an attending psychiatrist at Cobham Square Health Center and with Boston's Medical Center Psychiatric Emergency Services. While completing her medical residency at Yale, Dr. Isom served as the chief resident of diversity and inclusion. Dr. Isom's primary interests in our mental health are working towards eradicating racial and ethnic disparities, mitigating the impact of racial bias, and the use of community-focused population health approaches for psychiatric practice. At this time, we're just going to give a virtual round of applause in welcoming our speaker this afternoon. And right before we get started, we actually just have a poll for the audience to see if folks were able to attend the seminar last month in which Dr. Isom presented. So if you could just answer this question really quickly that just popped up on your poll screen, just so that we know who's in the audience and who's joining our collective today. All right, so it seems like a few more seconds for people to answer the poll if you haven't done so yet. All right, so it looks like the majority of folks were able to attend our last session, which is great. We welcome you back. We're so happy that you came to rejoin us. And then if you haven't attended the last session, we just ask if you have some time or interested in some of the conversations that we had last month, we have an archive of those materials that are saved, and the recording was saved as well. So we will make sure to distribute those to those who don't have access, and let us know if you have difficulty accessing that in the chat. All right, so next I will turn it over to our guest speaker for this afternoon to take it away. Thank you, Dr. Isom.
Thank you. So hello to most of you again, and to those who haven't met me yet, hello to you. So what I'm going to do is not take up a lot of time because I want to make sure there's time for us to have a conversation with each other. So I'm going to review this concept of equity-mindedness, and then review the steps on the equity roadmap that were provided to you all when you registered, and then really focus on some of the best practices that were mentioned in that material before we have our conversation together. And this topic is huge because a lot of the country right now is figuring out what to do with equity. I think we spent a lot more time thinking about, how we think about and can embrace diversity, somewhat more inclusion, but equity can be for a lot of people a very novel topic. And one way of helping us to get a sense of what this means for each of us as individuals, and also as collectives working within a clinic or a hospital or some other kind of space, is that we need to really have an equity-minded approach to what we do. And that includes having a level of racial consciousness, which means that you have an appreciation for your racial positioning, the racial positioning of others around you, what all of that means in the present day and what it has meant historically. And that also includes having an understanding about, an awareness of and an understanding about how you think about other people and how they might be similar to or different from you, how you make use of language, the kinds of actions that you take in your relationships with racially minoritized people. And this is something that everyone needs to be aware of. I have to be thinking about this even as a racially minoritized person. In addition to that, a really, really big piece of equity-mindedness is that you're willing to be accountable to history and its consequences in the form of inequities. So it's not a problem out there that's something to be fixed by policymakers, for example. It's a problem within the space that I exist in, and it's a problem that I have a responsibility to address. And then, of course, being able to address inequities requires you to understand the structural contributions just as much as the cultural contributions. And we'll have a bit more of a conversation today about what those cultural contributions contributions are. But we are not often trained to understand how structures shape our patients' lives, how they shape our own lives. So that's a really important part of developing equity mindedness that should be underlined multiple times. So on the next slide, I wanted to recap for you all, what are those 6 steps from the roadmap? And just to give the context again, this was a project that was primarily led by the Robert Wood Johnson Foundation. They took a lot of time to go through a lot of different materials, including a literature search and also interviews and conversations with health centers to get a sense of what were people doing and what was successful and what was not. And they came up with this roadmap based on that exploration. And they wanted to essentially communicate, how did people do it well? So what they came up with were these 6 steps. And the first is linking quality and equity together. Most of the time with quality improvement literature, it doesn't talk about equity. That's a really relatively new thing. And linking those 2 things together allows equity to be a part of conversations around patient safety, around workforce development, around well-being. It just kind of ties those 2 together. But another huge part of this too is having a culture of equity. And I would argue, in the spaces that I am in, that this is the one of the hardest parts. That culture means that people are equity minded, that they're able to see the value in collecting data necessary to reveal disparities, that they're able to engage in race talk, which means you're able to have a conversation about race, racism, whiteness, power dynamics, all those sorts of things. That's the culture necessary that allows people to coalesce, come together as teams to do the rest of these steps, which include diagnosing the disparity using really useful tools, such as fishbone diagrams that take into account elements of inequity that exist in the community. And the last time that we were together, we used an exercise to diagnose the disparity. That would be the start of an exercise using a fishbone diagram. We went through and we talked through, well, what could be some of the potential contributions to the disparity in suicide attempts for young children of color. So we did that portion last time, and that was really fruitful. And then from there, we would figure out what is feasible, what are the things that we came up with, do we have a lot of control over, and the resources to address. And then we would develop those priorities again in collaboration with a multidisciplinary team, pick one that's feasible and that we have the resources to address, and then design an intervention to address it. And then that intervention design, as discussed in the materials, can't just come from Dr. Isom's brain and one of her colleagues. It has to come from a group of people who can view the issue from a number of different perspectives. And they gave an example of where they had a depression program in a hospital, and they asked the community health workers, how should we structure our program? And the community health workers suggested that it be through the phone. They designed the intervention, they implemented it with patients, and they found that people were not participating. And then when they asked the patients why, they said that using their phone uses up their minutes. They have limited minutes, so they could not participate in the program. So they said that, that's an example of why it's important to ask the actual people what kind of intervention would make sense for them, and co-create that with people from within the health center. So the 5th step is securing buy-in, getting people engaged and interested in adopting what you're suggesting, which means that the intervention has to be, palatable in some ways. And it also has to be specifically attuned to where people are positioned and how that dictates their interest. So they talk through how a front desk person versus a physician in an office versus someone who works in the pharmacy, if they're all involved in the intervention, they have different needs, they have different priorities. So just making sure that you're paying attention to those things can help you sell your intervention and get them to participate and sustain their participation. And then 6, they emphasized again that you can have the best process ever in steps 1 through 5 and get to step 6, and it's still a lot to actually do the work. And they talked about some of the things that would be helpful to consider there. So what I wanted to do before we transition into talking is just recap some of the best practices that they had listed in the resource. And there's two slides for this one. And these are really, I found them really helpful to look through, and I think it will help us have a conversation. So the first one is about data and I'm currently navigating this right now. I know a lot of you all are as well. We often don't have good data. And I know in Connecticut, they recently had a bill passed specifically related to collecting race, ethnicity, and language data, and that took a legislative push. So sometimes that's necessary to get it at the state level, but even in our clinic level, it can be hard to get really good data. So they're just making the point here that you need that to do the really the best work, but you don't absolutely have to have it to do any work. So they make that point because they don't want us to not do anything because we don't have the data. So they suggest that if you can't access the numbers in the medical record, for example, that you might ask people, and you could have an interview or a focus group, for example, to get the information that you need. And then at the same time, parallel, make sure that your organization is working towards better data. The second piece here, foster a culture on the same slide, foster a culture of equity. This is the second part of the chart here in a darker gray. They're talking about here how important it is to have that culture in place and actively growing that culture before you can really be successful in these other steps. People have to understand why equity is important to something important to be strived for, and they have to understand how they fit in. So they have some suggestions here about what you can do, such as putting equity in your mission statement, having a really diverse workforce, and starting a consumer advisory board. And that can help, increase that culture. And then they also talk about in this third part here, making sure that staff have time, which is a very, very limited resource, at least in my setting, and that they're also held accountable. So not just talking about equity, but baking in time so people can develop their knowledge base and skills, and then putting it in, for example, performance reviews. So it's not just passive acceptance of the knowledge, but they have to demonstrate that I've done something relevant to equity, potentially tied to my advancement in this particular space. And then lastly, on this slide, they talked about making sure that you're thinking about multiple ways of addressing the issue. We often focus just on patients. If only they could read better, or if only they would, come to their appointments, or if only they would pick up their prescriptions, the problem would be solved. They're encouraging us here to think about what our role is, what role is the community playing, and other members of the healthcare team. So on the second slide, they have a few more suggestions for best practices. And the first one here in the light gray is around developing really a messaging that can be appealing to multiple groups and be tailored to multiple groups. So while I, as a physician, might be worried about how much support I have to accomplish the task in a day, and that can be paid attention to in the designing of the intervention, here they're suggesting the frontline staff might be worried about how extra paperwork might disrupt the patient flow. So they're really encouraging you in your messaging to get people to buy in by really being attuned to their needs. And again, if that culture of equity is present, people will hear you out a bit more. In the dark gray, they're talking about the point I made just on the prior slide, that you really want people who are going to receive your intervention to be involved in that discussion. And I cannot stand, as a Black person in my clinic, I cannot stand for and represent a Black patient if we have two different lived experiences. Our lives are different. We live in different places. We have different needs. So I am Black. However, I do not represent Black patients. They should actually be reached out to and spoken to about what their perspective is on the idea. The third in the light gray is talking about being flexible, essentially. You might have a plan for what you want to do, but life happens. So they gave one example of where an intervention was where a patient had to watch this video, and then they had to come into the clinic for their appointment. People were coming into the clinic, had not watched the video. So instead of just saying, never mind, they set up a room for people to watch the video in the clinic, again, showing flexibility. And then lastly, being really practical and realistic about how much time these things take. So they talked about how process is something that you might notice sooner than outcomes. So process might be, we increased how much data we have available that's accurate, or we increased the number of people that we screened. But the outcome of whether or not those numbers are different, like one group might be more depressed based on these screening tools versus others, those numbers are outcomes, and that can take longer. So in your messaging, letting staff know that we're doing the work and we want to see results immediately, but different kinds of results will come out over time. So that is a recap of the best practices, which again are available at the end of that roadmap document. And I think for today's conversation, we're mostly going to focus on having a conversation about creating a culture of equity. So I'll pass it to the group facilitator to introduce that topic. So thank you.
Thank you.